Great, thank you so much. So I am one of the ID pharmacists over at the VA. And when I was putting this together, my goal was to kind of simplify this because we have a lot of second-year fellows who are going to be out practicing in the world on their own relatively soon. So I wanted to simplify this as much as possible, but the concepts are also applicable to our first years as well. So today what we're going to do is we're going to just review some pharmacokinetic parameters. And then we're really going to focus in on how to dose and monitor patients for when we use aminoglycosides, so both extended interval and conventional, and then IV vancomycin. So we'll just start with the PK overview. So this is a concentration versus time curve, which you're probably familiar with. So essentially, when you give a dose of a medication, it starts to get absorbed. And then when the infusion ends, it'll distribute into the serum and the body tissues. So you can see a couple of terms on your screen here. So Cmax is obviously the highest concentration there. Now at the bottom, we have Cmin, which is the minimum concentration. You'll see the MIC, which becomes relevant when we're talking about these doses in relation to specific bacteria. And then the area under the curve. So essentially, one of those parameters that we're going to talk about more so with vancomycin than the aminoglycosides. So other concepts that we'll discuss are steady state. So just by definition, that's when the rate of drug administration is equal to the rate of drug elimination. And usually that takes about 4 to 5 half-lives of the medication. So you really don't see steady state until a couple of days into therapy generally. We'll also talk about loading doses, more so with vancomycin than the aminoglycosides. So you have another concentration time curve on this slide here, and basically it's showing you the difference between exposure with a regular dose and then if you did give a loading dose. So you can kind of see the difference. When you give a loading dose, you're not getting to steady state any faster, but you are achieving therapeutic concentrations sooner. So this is important to keep in mind. We have like a septic patient or someone who's unstable, where we really want to make sure that they're getting therapeutic concentrations up front instead of it taking several half-lives or days to reach that point. All right, so these are pretty much outdated at this point, but in terms of infectious disease and antimicrobial stewardship, part of that is optimizing the antimicrobial dosing based on individual patient characteristics. And we're going to talk about that a lot more with the vancomycin and those updated guidelines that were updated last year. But by kind of optimizing the dosing of these patients, we can maximize the efficacy and prevent or reduce the emergence of resistance and just be good antibiotic stewards in general. All right, so usually I like to have this be interactive, which is a little bit difficult on this platform. So I did include some animations to try and, get us involved as much as possible. So we're looking at the antimicrobial target parameters on this slide. So for concentration-dependent antibiotics, the most common ones that we see, and one that we'll be talking about today, are the aminoglycosides, also quinolones, metronidazole. And the goal here is to maximize exposure because the higher above the MIC that you get, the more bactericidal activity there will be. That second category that you see is AUC dependent. So this is where vancomycin is going to come into play. And what we want to do with Vanco is maximize the area under the concentration time curve, which I showed you on that first slide. And then finally, some of our antibiotics are time dependent. So these tend to be the beta-lactams, where we generally want about 40 to 60% of the time above the organism's MIC. So we're optimizing that duration of exposure in relation to the organism's MIC. So right now, we don't have any therapeutic drug monitoring for these drugs, but that may change with Dr. Canella's upcoming research. So again, another concentration time curve. So this is showing you the exact same information that we saw in the previous slide. But for those of you who are visual learners, it might be a little bit easier to see in this manner. So obviously the aminoglycosides, we're looking at concentration dependent. So the highest concentration above the MIC. Area under the curve for Vanco, so it's this shaded area under the curve here, and then the time above the MIC for the penicillin cephalosporins, which we are not going to be talking about today. All right, so we'll just jump right into it. I'm going to start with the aminoglycosides because, believe it or not, they are a little bit easier to explain and to monitor than the vancomycin. So for the focus of this presentation, we're going to be talking about amikacin, gentamicin, and tobramycin, and not necessarily any of the newer agents like plazomicin. So as you guys probably know, these antibiotics have a very narrow therapeutic index. So some of the toxicities that we want to watch out for are nephrotoxicity, which in general is reversible, and ototoxicity, which sometimes can be irreversible. And when we look at risk factors that predispose someone to toxicity, they kind of fall into two categories. So we have the unalterable factors, so age and pre-existing renal disease or dysfunction. So we want to use caution in our older patients and those with chronic kidney disease or AKI. And then we have the potentially alterable factors. So, concomitant use of other nephrotoxic agents. So are they on an ACE or an ARB as well? Did they just get contrast, or are they going to get contrast for a procedure? So things that might limit our use of aminoglycosides or cause us to, use a different agent overall. So again, this concentration time curve, we know that our aminoglycosides are concentration dependent. So you'll see this kind of throughout the presentation. Another thing that's important to note with the aminoglycosides, towards the right hand of your screen, something called a post-antibiotic effect. So essentially what this means is even when concentrations fall below the organism's MIC, there is still a period of antibiotic activity. So there still will be some bactericidal activity even when the concentrations start to fall off. So there's two different ways that we can dose aminoglycosides. We have the conventional dosing, which is typically low doses given pretty frequently. So maybe gentamicin, 1 milligram per kilogram, Q8 hours. And then we have extended interval or nomogram dosing, which tends to be the preferred dosing for most patients. And what this is, these are higher doses given much less frequently. So it's usually once a day, or it can be a little bit longer than a day as well. So again, another concentration time curve. So this is showing you the differences between a once daily extended interval regimen in the blue versus your conventional regimen in black. So you can kind of see just the differences in exposure over a 24-hour period. So with your conventional regimen, you can see the Cmax is between 4 and 6. And you're giving multiple doses per day, versus that extended interval dosing, your Cmax is up here at 20, and then you don't give any other doses for the rest of the day, so that drug has time to kind of excrete from the body. All right, so in general, when we're talking about aminoglycosides, we want to use a patient's ideal body weight. So I have the equation for calculating that up on the slide here. Of course, there are exceptions to this. If we have someone who's underweight, we don't want to be overdosing them, so we will use their actual body weight. If you have obese patients, this is when we'll tend to use adjusted body weight. And again, that equation is up on the slide. And then when we're using select extended interval nomograms, so when I introduce the nomograms, I'll show you which one we might not use ideal body weight for. So like I said, extended interval or nomogram dosing is preferred in most cases. There are some patients where we don't want to use it. So essentially, patients who might have an altered volume of distribution or might be third spacing, so burn, pregnant, trauma patients. We also don't want to use this for patients who have fluctuating renal function, and this includes our dialysis patients. And we also don't use nomogram dosing for synergy. So if we're using it for endocarditis, for example, we will use conventional dosing. So an important thing to note is that age alone is not an exclusion factor. We know that's one of the unalterable factors that can preclude someone to aminoglycoside toxicity. But usually these medications are cleared within a day or so. So the nomogram dosing is not a contraindication as long as they don't meet any of the criteria that are on the screen there. You know, if you do have someone who is elderly, which our patients at the VA tend to be, you can use smaller doses. But just keep in mind that you can't really get follow-up levels because there's no nomogram based on that smaller dose. All right, so there's a number of benefits of using this extended interval dosing. So we already know aminoglycosides exhibit that concentration-dependent killing. So what we want to do is optimize that peak to MIC ratio to a value usually of greater than 10 to 1, and that's really going to maximize our bactericidal activity. So if you think back to that concentration time curve that kind of compared the nomogram dosing to the conventional dosing, if you remember, the peak that we got there was 20 compared to a peak of 4 or 5 with the conventional dosing. So we're getting nice high concentrations above the MIC. Again, we talked a little bit about that post-antibiotic effect. So we're going to get bactericidal activity even once the concentrations decrease below that MIC. And then finally, the best benefit of this is there is less toxicity with extended interval dosing. So we're allowing the aminoglycoside to be cleared from the body, so you're getting less accumulation in the kidneys. Another thing to note that is kind of specific to aminoglycosides is they can develop what's known as an adaptive post-exposure resistance, which is essentially when they're exposed to an aminoglycoside, there can be less bacterial uptake of that drug with prolonged exposure. So essentially, less frequent dosing with longer periods of either low or drug-free intervals, like you'll see with extended interval dosing, can help reduce the incidence of this adaptive post-exposure resistance. So there's a number of nomograms available, and I kind of outlined the 3 major ones on your screen there. So we'll kind of go through each, and I'll show an example of what they look like, and we'll go through a sample case together. So the Hartford Hospital nomogram, which is that first one that you see, is typically used for pneumonia and severe septic patients. And you'll use 7 mg per kg of either gentamicin or tobramycin in this case. The two nomograms on the right-hand side of your screen are the Barnes-Jewish and the Urban-Craig nomogram. So if your patient does not have pneumonia or severe sepsis, then these are the nomograms that you're going to be using. In addition, these are the two nomograms that will account for aminoglycoside dosing. So if you need, amikacin dosing. So if you need to use amikacin for a specific reason, you will need to utilize one of these nomograms. So if you have the antimicrobial stewardship booklet from this year, I will be referring to some of the pages that these nomograms are on. In the booklet, we only have the Barnes-Jewish nomogram, mostly because of our patient population here tends to be a little bit older, and that's just our default nomogram. But if you tend to go to a hospital that has a younger population, then you might utilize the Urban-Craig nomogram. So this slide here is just looking at the Hartford Hospital nomogram. So again, gentamicin, tobramycin, 7 mg per kg. We're using it for patients with pneumonia or sepsis. And you'll note that you will plot the level after the start of the infusion. The other nomograms that we talked about, so Barnes-Jewish nomogram. This is used for most other indications. And then we have the Gent and Tobra nomogram on the top and amikacin on the bottom. So these are the primary nomograms that we use here. On the right side of your screen is the Urban-Craig nomogram. So you'll see it's very similar to the Barnes-Jewish nomogram, with the exception of the heart is an extra category here. So in select patients, if they're very young or if they have like an augmented renal clearance, occasionally patients may be best suited to a Q12-hour regimen instead of Q24 hours. All right, so now we're going to go through the steps to choosing and monitoring a regimen for an extended interval aminoglycoside. So if you have your booklet, this is on page 27. So I tried to simplify it as much as possible and break it down into, what are the steps that we need to do to, determine what nomogram to use, what dose are we going to use, and how do we monitor it. So the first step is obviously choosing the appropriate nomogram. So the first thing we want to do is ensure that there's no exclusion criteria for extended interval dosing. So as long as the patient doesn't have unstable or fluctuating renal function, if they are not on dialysis, they are not pregnant, have ascites, or any sort of significant burns or trauma, and then if we are not using this for synergy for something such as gram-positive endocarditis, then we can go ahead and use the extended interval nomogram. And again, I put the indications for the Hartford Hospital and the Barnes-Jewish or the Urban-Craig nomogram up on the screen. So the step 2 is once you determine which nomogram to use, then you want to calculate the dose of the aminoglycoside. So this algorithm that's on your screen and it's in your booklet kind of tells you exactly what dose you're going to be using. So in most cases, you're going to be using ideal body weight. So if you're looking on the left-hand side of the screen, we have your Barnes-Jewish nomogram. We'll use ideal body weight unless they're underweight or unless they're overweight. And then on the right-hand screen, we have the Hartford Hospital nomogram. So this is another exception to that rule. Typically, we tend to use actual body weight, but if the patient is obese, more than 120% of their ideal, then we will use adjusted. So lots of little caveats. So it's nice to refer back to this when needed. So gentamicin and tobramycin are available in vials of 40 milligrams per ml, and amikacin is available as 250 milligrams per ml. So when I put in these doses, typically I like to round them to the nearest 20 or 40 milligrams or 125 or 250 for amikacin, just to make the dosing and the preparation of the drug a little bit easier on everybody. Step 3, we want to determine the dosing interval. So post-dose levels will tell us what the optimal dosing interval is for our patient. And typically that's done at least 6 to 14 hours after the dose is given. Now, there are some nuances depending on which nomogram you use. So the Barnes-Jewish nomogram, you're going to start counting after the infusion has ended, whereas the Hartford Hospital nomogram, you start counting at the start of the infusion. So just something to keep in mind. And what's nice about this is you plot the level on the nomogram, and then you choose a dosing interval based on where it falls. Occasionally, you will have a level fall on the cusp of 2 dosing intervals. So this is where you want to use your clinical judgment and decide, do I want to be a little bit more aggressive with my dosing, or can I back off? So this is just an example of, this is the Barnes-Jewish nomogram, but at the bottom you can see each nomogram will tell you, are you measuring after the end of the infusion or the start of the infusion? And then wherever your level falls, in this case, this is a level of 6, 8 hours after the end of the infusion. So you can see it falls in that Q36 hour interval. So we would want to make sure that our next dose is 36 hours after that first dose. All right, and then continued monitoring. Obviously, if our therapy is expected to continue, we have one of 2 options. You can either get a trough level immediately before the next dose is due, and you would want that less than 1 for Tobra or Gent, or less than 4 to 8 for Amikacin. Or you can go ahead and repeat a post-dose level and go ahead and plot that on the nomogram and ensure that you're still in the same dosing interval. Obviously, if there are any significant changes in renal function, volume, or clinical status, then you want to go ahead and repeat that post-dose level to see if any changes need to be made. All right, so we'll go through this example case together. So we have MC, who's a 50-year-old male patient who is admitted with a chief complaint of 4-day history of dysuria, frequency, and urgency, despite taking the oral Cipro that his primary care doctor prescribed. He got urine and blood cultures done in the ER, and he is afebrile, vital signs stable. So his urine culture comes back, and this is what he's growing. So it's a relatively drug-resistant Pseudomonas. If you can see, it's susceptible to amikacin and tobramycin. You can pretend that you are at the VA right now, and we don't have AV-Cas or Zerbaxa due to shortage, so we are stuck using an aminoglycoside to treat this. And then just some pertinent patient information. He weighs 83 kilos, and his ideal body weight is 75, and his renal function is good. All right, so the first thing we're going to do is choose the appropriate nomogram. So I kind of took a little portion of the algorithm and put it up at the right-hand side of the screen here. So things that we want to look at are patient-specific factors and then indication for use. So looking at our patient, we don't have any contraindications to nomogram dosing, so we're going to go ahead and use that. And for our indication, we know we're treating a UTI, and he's afebrile, vital signs stable. There's no hemodynamic instability. So we're going to go ahead and use the Barnes-Jewish or Urban Craig nomogram. We're going to use the Barnes-Jewish nomogram in this case because that's what we have here. So we can choose between gentamicin, tobramycin, or amikacin. So which aminoglycoside are we going to choose? So if I pull up his culture again, you'll see it's only susceptible to Tobra and amikacin. And if you're familiar with the breakpoints for these organisms, tobramycin is going to be the better option in this case because the MIC is less than or equal to 1. All right, so next what we're going to do is we're going to calculate the dose. We know we're using the Barnes-Jewish nomogram. Again, I put his patient characteristics up on the screen there. So he's not underweight, so that's good, and he's not obese. So we can go ahead and use his ideal body weight to calculate his dose. So we want to do tobramycin 5 milligrams per kilogram times the 75 kilos. That is his ideal body weight. And that equals 375 milligrams. If we want to go ahead and round to the nearest 40, the dose would be Tobra 380 milligrams. So we'll go ahead and assume that he got that dose, and now we're going to get a post-dose level. All right, so I pulled up the nomogram on the screen there. So for example, if we had a level drawn 8 hours after the end of the infusion, that came back at 4. That is the blue star that you see on your screen. So that would fall in the Q24-hour dosing interval. So we would want to make sure we give our next dose 24 hours after that initial dose. For example, if we had a 13-hour post-dose level of about 2.5, that's represented by the red star on your screen. So you can see that this kind of falls on the cusp between Q24 versus Q36-hour dosing. So this is where we'll use our clinical judgment. Is his renal function stable? Is he septic? Do we need to be more aggressive with the dosing, or can we be a little bit less aggressive? So, he's stable. His renal function hasn't changed. It would not be unreasonable to do Q36 hours because we know we are still going to get that post-antibiotic effect. All right, so we'll go a little bit faster through the conventional aminoglycosides and how to choose and monitor a regimen for them. So basically, if a patient is not eligible for nomogram-based dosing, what we're going to use is conventional dosing. And again, I have those indications up on the screen for you. So in terms of determining the dose, generally we're going to use ideal body weight, unless of course the patient is underweight or overweight, and then we have the appropriate weights listed up there. When we calculate an initial dose, you're going to see that these doses are much lower than the ones that we used for the nomogram dosing. So for Genta and Tobra, it's about 1 to 2.5 milligrams per kilogram. And then for amikacin, we have anywhere from 5 to 7.5. The next thing you want to do is determine the dosing interval. So first we're going to calculate the patient's creatinine clearance, and in most cases we're going to use the Cockcroft-Gault equation. If your patient is underweight, typically we want to round up the serum creatinine to 1, but we do not typically do that in our elderly patients. And go ahead and use adjusted body weight for your obese patients. We do have a special population here of spinal cord injury patients. So when you're at the VA, or if you go somewhere where there's, spinal cord injury patients or patients with really low muscle mass, you can consider using the cystatin C to estimate the GFR. So cystatin C is basically a protein that's produced by cells of the body, and it can be a better predictor of renal function in these specific patients. And I have a link to, a cystatin C calculator that will correlate an estimated GFR on the screen there. So finally, you want to select a dosing interval based off your renal function. Typically, we'll do Q12 here just because our patients tend to be a little bit older and they don't tend to tolerate Q8-hour regimens. If you're working somewhere with very young patients, then Q8-hour dosing could be an option. And then monitoring, we're going to want to wait till steady state, so typically after 3 or 4 doses. And in patients with normal renal function, again, that's about 3 or 4 doses. And peaks will be drawn about 30 minutes after the end of the infusion because these drugs really don't need a long time to distribute. And then troughs are drawn about 30 minutes prior to infusion. So the most important thing is looking at the administration time of your aminoglycoside and the time that the sample is drawn. And that's going to be important in determining Is this a true trough, or was it falsely elevated or underestimated? So again, on the screen, I have our desired peaks and troughs for the different aminoglycosides for different indications. So obviously, if we're using it for synergy, we don't need super high peaks. But if you're using it for something like pneumonia, those tend to be a little bit higher. So in general, our peak levels will correlate with efficacy, and our trough levels reflect risk of nephrotoxicity. So in general, if your peak is good, but your trough is too high, we want to extend out that dosing interval. If your peak is too high, but your trough is good, we're going to change the dose. And then if your peak is too low, but your trough is in range, we can make some adjustments there as well. Obviously, you're going to want to use pharmacokinetic equations to determine that optimal dose based on your patient-specific parameters. So I have some equations up on the screen. It's not really, feasible to do that, or expect you to do that. So if you don't have a pharmacist with you, I'm going to show you a nice resource that you can use. So this is actually VancoPK website, which has dosing for both Vanco and aminoglycosides. But essentially what you can do under the patient data side is you can input all of the data, their dose, their peak, when the peak was drawn, the trough, and when the trough was drawn. And you can just hit calculate. And it's going to calculate all their pharmacokinetic parameters in the middle for you. And it's going to spit out another dose for you. So this is recommending, 170 milligrams Q18, but maybe you don't have Q18 hour dosing where you are, so you can go ahead and put in a different regimen and hit calculate, and it'll tell you, okay, if you wanted to use this dose and this interval, then your estimated peak is going to be about 3.5, and your trough will be, less than 1. All right, so now we're going to jump into vancomycin. So if you are familiar, there were new vancomycin guidelines that came out last year that were kind of a total overhaul of how we were monitoring vancomycin in the past. So at the end, I'd be interested to hear from you guys about if the other institutions have already transitioned over to this new monitoring, or if they are in the process of doing so. So just an overview of Vanco. We know this is a glycopeptide that exhibits bactericidal activity by inhibiting cell wall synthesis and repair. The PK/PD parameter that we're looking for here is area under the curve compared to that MIC value. So again, we have that concentration time curve on the right. So we're looking at that shaded area under the curve there as the area under the curve to MIC. So in terms of pharmacokinetics, obviously, after the infusion, the drug has to distribute from the blood to the rest of the body. And the volume of distribution for Vanco is quite a bit higher than those for aminoglycosides, so it tends to distribute into the tissues a lot more, and that includes adipose tissue. So that takes a little bit longer. So we're going to see that we're waiting a little bit longer before we get some levels for Vanco. In some patients, a large percentage of the drug distributes to the tissues. So if you're obese or have certain other factors, that might contribute to a larger percentage being distributed versus other patients might have a smaller percentage of distribution. So basically what this is getting at is that there's a huge patient variability when we're looking at doses, which makes dosing very difficult, especially in our obese patients. So another concentration time curve on your slide there, and you have several different regimens. We have one in black, one in red, and one in blue. And basically, when we were monitoring in the past, we were looking at trough levels only. And the problem with that was that the trough is the single point of the concentration time profile. So you can see these 3 different patients have vastly different area under the curve, but they all have the exact same trough value. Like we said, the volume of distribution can vary a great deal between patients, and along with that, that area under the curve exposure is also going to vary. So if you didn't know, the things that have changed the most are, if we're looking at area under the curve, now we're drawing both peak and trough levels in order to calculate patient-specific characteristics to determine that optimal dose regimen for them. So way back when Vanco, decades ago, we used to monitor the peak levels, but this kind of fell out of favor in the 90s because trough levels were much easier to look at, and we were using them as a surrogate marker for efficacy, as a surrogate marker for that AUC. So the big problem came in that, we have a lot of patients with obesity and morbid obesity. And like we said, there's variable distribution and elimination, especially in these patients, which can lead to a number of things. Obviously, we can get subtherapeutic concentrations, which can lead to treatment failures. In some cases, we're using higher doses to kind of account for that higher body mass, and that can lead to an increase in nephrotoxicity, all of which can, increase the cost of therapy, the length of stay, and ultimately mortality. So it's not only the obese patients that have altered, pharmacokinetics, obviously patients who are critically ill, if they have any sort of volume of distribution changes, especially in pregnancy. Some patients may be super metabolizers if they're young, maybe they have cystic fibrosis. And then some patients just do not follow population pharmacokinetics. So the best thing that we can do for these patients is draw both a peak and a trough concentration, and we can calculate their specific pharmacokinetic parameters, so their volume and distribution, elimination rate constants, things that will determine the optimal regimen for them. So just kind of summarizing what's in these new consensus guidelines. Obviously, our old guidelines were looking at, troughs. We wanted to a goal of 15 to 20 that would equate to about an AUC of greater than 400. And then these new guidelines, trough-only monitoring is really going out of favor. We will use it in select patients that have CNS infections where we want to make sure that we're getting penetration, but for most other patients, we will be using the AUC monitoring. So, like I've kind of emphasized, the optimal way to manage Vanco is through the area under the curve guided dosing and monitoring. And we want to target an AUC of about 400 to 600. So not everyone is going to need monitoring, but it is definitely recommended for patients who are receiving aggressive doses for serious infections, if they're at risk for nephrotoxicity, if their renal function is fluctuating, or if they're on prolonged courses of therapy, so at least 3 to 5 days. And the other new thing that was in the guidelines is that loading doses typically should not exceed about 3,000 milligrams, which is an increase from the previous guidelines. So when we look at choosing an AUC target, it's important to note that most of the studies that were done were looking at serious MRSA infections. And you can kind of see on the screen here what the efficacy target was for all of the different studies that are listed. So the guidelines actually recommend an AUC of 400 to 600. And locally, what we're doing is we're looking at an AUC of 400 to about 550, because once you get above 550, there is an increase, a corresponding increase in nephrotoxicity. So these are the new PK targets that we're looking for. So mild infection, if it's just a UTI or a simple cellulitis, area under the curve of about 400 to 450. Moderate to severe is basically any other infection, and we're looking at an AUC of 450 to about 550. And then again, that outlier is our CNS infections or meningitis. We want to make sure that our troughs are still at least 15 to 20, regardless of what the AUC is. So when we look at specific MICs for MRSA infections, typically we don't have these within the first 72 hours because the culture has to come back and we have to have susceptibilities for it. But most MICs for MRSA are less than or equal to 1. So we'll just go ahead and assume an MIC of 1 for most patients, and then you can make adjustments based on your cultures as needed when they return. Right now, because all of those studies looked at MRSA infections, we have a lack of evidence to suggest reducing the dose if that MIC comes back at something lower than 1, like 0.5. But obviously, if there's any concern for visa, then we want to be using an alternative agent, especially if that MIC is greater than or equal to 1.5. All right, so I have another concentration time curve for you that's showing you pretty much the population parameter, PK parameters for vancomycin. So I have a couple of equations up on the side there. So what we're looking for in these patients are obviously not only the trough level represented by that blue star, but we also want a peak level. And by getting those 2 points in time, we're able to calculate all the PK parameters that we need. So I'm not going to bore you with the math of it, but we do, the take-home point is that you need both the peak and trough within the same dosing interval to be able to calculate this appropriately. So what do we do once we have those 2 levels? Obviously, we're calculating the patient's area under the curve. So we want to do this with basically all the patients who are listed on the screen. So if you have an invasive infection due to Staph aureus, if therapy is going to be ongoing for more than 5 days, if you're treating a serious infection, or you have an obese or an elderly patient where you want to make sure that you're not overdosing them. There are a few cases where we still will use trough monitoring. So like we said, meningitis and CNS infections, because we want to make sure we're getting adequate concentrations at the site of infection. The other scenario is patients who have unstable renal function or are on renal replacement therapy. So if they're on hemodialysis, peritoneal dialysis, or CRRT. And not everyone needs Vanco levels. So in these specific cases, Vanco monitoring is unlikely to affect patient outcomes. That's stated by the guidelines. So surgical prophylaxis, obviously you're only giving a few doses. Less serious infections, such as uncomplicated UTI or simple cellulitis. These tend to be short-term use of vancomycin. So levels are not necessary. So we'll go through together how to choose and monitor an IV Vanco regimen. So again, I will make this as simple as possible. The first thing you want to do is gather and input your patient data. So age, gender, height, weight, and creatinine. So these are all the parameters that you need to, all right. I know. Sorry about that, guys. To calculate the PK parameters that we're going to utilize. If we have any amputations, if the patient is missing, they had a right BKA or a bilateral AKA, that's going to affect how much Vanco is distributed. And then what's our indication and our goal PK parameter? So again, I went ahead and put those on the screen just for your reference. So these are all the equations that kind of go into determining what's the best Vanco regimen. And I don't expect you to use any of these, but they're there because you need to be aware that there's a lot of math that goes into calculating the correct regimen. But here we have a vancomycin calculator, and what I used for the purposes of this presentation is, again, this VancoPK website, which you can access, on your mobile device or computer, anywhere with an internet connection. And basically they use the same parameters, and they will use those equations to calculate an optimal dose for you. All right, so once you plug everything into the calculator, you'll have the option to consider a loading dose. So like we said in the beginning, that loading dose does not get you to steady state any faster, but it will get you to therapeutic levels faster. So if you have someone who's critically ill, you want to go ahead and give them a loading dose. On the right-hand side of your screen, you can see the differences in area under the curve compared to, over each dose in someone who did not get a loading dose. So that's why we need to wait till steady state to get our levels, because there's great variability in the AUC, especially early on. So if you are going to use a loading dose, typically we'll use 20 to 35 milligrams per kilo if their BMI is less than 30. And then we'll use 20 to 25 if their BMI is greater than 30. And like the guidelines said, we typically don't want to go over a loading dose of 3,000 milligrams. All right, so once you have your loading dose, then you want to choose a dose and dosing interval. So you can basically choose one of the regimens that's suggested by the calculator. Now, I don't want you to use the calculator by itself. You should be using clinical judgment. So you want to make sure that the regimen it's suggesting makes sense, especially for your patient. So I have some creatinine clearance cutoffs and dosing intervals to consider up on the screen there. I started the every 8 hours mostly because, with our patient population at the VA, our patients tend to be a little bit older. They might have some renal impairment, and unless they are less than 50 years old, in my experience, they really don't tolerate every 8-hour dosing very well. The next thing you want to do, which is a little bit more important for pharmacy than from the physician standpoint, is just choosing an infusion time. So minimum infusion time is going to be 6 to 8 minutes. And then for every 500 milligrams that you go over, you want to extend that infusion time by another 30 minutes. And obviously, if your patient has an adverse reaction like red man syndrome to the infusion, you want to slow that infusion even more. And sometimes you may want to give Benadryl as a pre-medication. So in terms of monitoring, all the information that you put in the calculator is derived from population estimates. So really it's just a best guess dose. But when we get levels, that's when we can actually decide what the patient-specific regimen should be. So again, I have an algorithm on here to kind of guide you through what kind of monitoring you need based on the type of infection. What kind of levels do you need to, figure out that AUC or trough? And then what are the targets? So I'm not going to spend too much time on here, but it is in your booklet if you need to refer back to it. So when we talk about peak and trough levels, these are the two levels that we'll need to calculate the AUC. We typically want to wait until steady state to get those because of the variability that I showed you in area under the curve. But if you do give a loading dose, you can get it a little bit sooner after that first maintenance dose. Depending on the dosing interval, this is going to decide when you get your peak and trough level. So if you're on a Q8 or Q12 hour interval, usually it'll be after the third, fourth dose. If it's a daily regimen, the second or third. And then, like aminoglycosides, we want to make sure that the levels were obtained in a timely fashion. If they've been drawn, more than 2 hours outside of the desired time frame, it's really not going to be super reliable. So it's better to just redraw those levels than to try and calculate what they would be if they were drawn correctly. So once you have a patient who is stable on their regimen, you don't need to get levels very frequently. So as long as their renal function doesn't change or they stay hemodynamically stable, you can get weekly trough levels once you get that area under the curve at goal. But obviously, if anything major changes, their weight, their renal function, clinical status, then it would be prudent to kind of repeat a peak and trough to make sure that area under the curve did not also change. So we'll go through one case together. So we have TA, who's a 72-year-old male admitted for treatment of osteo. He underwent a right TMA, cultures and path are pending. He's afebrile and stable, but he does have a prior history of MRSA from bone cultures. So I have his height and weight and serum creatinine up on the screen there. So what dose of Vanco would you want to use for this patient? So what we can do is we can go to the Vanco calculator and basically plug in his patient data. And it's going to tell us, okay, these are some regimens that would, achieve, a good concentration. Do we need to use a loading dose for him? I don't think so. He's stable. There's no urgency to get him to the therapeutic range, so it's not necessary, but it's also not wrong to give him one. So right over here, if you can see the suggested dose, we don't have Q18-hour dosing here, so I went ahead and just did the same dose at a longer interval. It's telling me my area under the curve, based on population kinetics, would be about 502. So for an osteo, I would want to target 500 to 550, so we'll go ahead and use that dose. So he gets started on that. So when do you want to obtain levels? So obviously our peak and trough around the 3rd and 4th dose. And I have some examples that came back. So his peak came back at 27.5 and his trough was 15.4. So if you go back to your calculator, there's a tab that says steady state peak and trough. And again, just like your aminoglycosides, you can put in the dose, your levels, and when the levels were drawn, and hit calculate. And it's going to tell you, okay, these are the parameters specific to your patient. And then if they're not in range, it's going to suggest an alternative dose that would put the patient in range. But as you can see here, our patient, area under the curve is still about 505, so that's perfect. So we're not going to make any changes to his regimen. The last thing I wanted to go through, because it does come up pretty frequently, is IV Vanco for patients on hemodialysis. So this is a little bit different. So for our hemodialysis patients, the first thing we need to do is give a weight-based loading dose. And there is an algorithm on your screen. It's usually between 20 to 30 milligrams per kilogram of actual body weight, depending on their clinical status and then how soon their next hemodialysis session is. So after you give that loading dose, there's really not a lot of thought involved. You can typically start with 500 milligram supplemental doses after dialysis. And then what you want to do, we're not getting peaks and troughs in these patients, but we will get a pre-HD level typically before the 2nd or 3rd supplemental dose. And I do this with morning labs, especially if the patient is anuric, because if you're getting it at 1 a.m. versus 8 a.m., if they're not making urine, the level should be about the same. And here we use the Revclear Max filters, which remove about 40% of Vanco in a typical 4-hour session. So, wherever you end up working after fellowship, it would be a good idea to, see what filters they use in hemodialysis, because a different amount of Vanco might be removed during a session. So we'll go through this last case together, and then I'll open it up for questions and comments. So obviously today is Wednesday. We have Mr. L, who's a 66-year-old male veteran, admitted again for treatment of osteo. He weighs 80 kilos and has a creatinine of 4.4, but he is end-stage renal disease and he gets dialysis Tuesday, Thursday, Saturday. So his last hemodialysis session was yesterday afternoon. So in the ER, he got a dose of 1 gram of Vanco. All right, so do we think his loading dose is sufficient? If we go back to that algorithm on the previous screen, we can see, okay, probably within the next 36 hours or so, he's going to get dialysis. So, if we do 25 mg per kg and he weighs 80 kilos, it's probably not sufficient. So we want to go ahead and give him, another gram now to equal about a total loading dose of 2,000 milligrams. So what Vanco regimen will you choose for him? Well, he's on dialysis, so we can go ahead and put him on 500 milligrams post HD. So his first 500 milligram dose will be tomorrow after dialysis. All right, so now it's Saturday and we got a random level with morning labs, and that level came back at 16.2. So is this at goal? Yeah, our goal for hemodialysis for osteo would be 15 to 20, so this is perfect. And do we want to change or continue the current regimen? So he's at goal, so I think we can continue it, no problem. All right, so to sum up, in general, both for aminoglycosides and Vanco, when we're using aminoglycosides, we try to use extended interval nomogram dosing when we can. Our dosing weight for aminoglycosides and Vanco is a little bit different. In general, we want to use the ideal body weight for aminoglycosides because of that low volume of distribution. And in general, for Vanco, we're tending to use actual body weight because it distributes a little bit more. And then obviously close monitoring and dose adjustments are key to preventing toxicities and maximizing efficacy. So I'll go ahead and open it up for any questions or comments. I'm especially interested for those of you who have recently been at TGH or Moffitt, if you are using the AUC-based dosing for Vanco, or if that is still in progress.